All right, thank you guys. Well, today we are going to talk, tell me if you can't hear me at all. We're going to talk about colon cancer and why it's preventable and what we can do about that. I want this to just be, interactive, so stop me if, you have any questions along the way. We'll get through our slides in plenty of time, and I can take questions at the end. So again, I'll just point out a few little things as you see. This is the colon cancer awareness symbol, and March is Colorectal Cancer Awareness Month. So hopefully you'll see more things throughout the news and media about colon cancer prevention. This kind of falls at a good time for us. And I'll talk a little more at the end, but we're actually sponsoring the first 5K run and walk here at Pennington on April 16th called Get Your Rear in Gear. So look for more information about that to come as well. All right, so colon cancer is it's very important, and why? It affects tons of Americans every year. There's 150,000 new cases diagnosed each year, and it's the second leading cause of overall cancer deaths in America, accounting for 50,000 deaths a year. And I'm just going to show you a few statistics, not to bog you down, but if you look at all mortality in the United States, cancer ranks number 2, and this includes all cancers, second to heart disease. But the discouraging thing is when we look from 1950 to 2005 and causes of deaths, we see in heart disease, wow, we've made great strides. Strokes or cerebral vascular disease, likewise. Infectious diseases, we've more than half them. But cancer deaths, we really haven't made much progress. So we think that we're doing really good, but really our mortality hasn't seen much improvement. So what's the probability of you developing cancer in your lifetime? Well, when we look, here's all the different cancers. It's 1 in 8 for breast, 1 in 16 for lung, but still 1 in 19 for colon and rectum. And if I'm here telling you it's preventable, why is that number so high? And that's the question, I kind of am asking. I think we're not doing a good enough job in this community and country overall in educating people. There are some genetic predispositions, and I'll get to that, but it really counts for less than a quarter of the causes of colon cancer. 75% of them are sporadic or just happen in anyone. When we look at cancer incidence, or this is new cases of colon cancer in women, you can see that it really hasn't changed. So we're, again, not really making improvements. If our screening were better, I would like to see this line making a downward trend. Likewise, when we look at cancer deaths, we do see we've made progress. So this is with new chemotherapy and improved surgery techniques. So people are surviving better, and that's with modern medicine. But still, it's the third leading cause of cancer deaths in women. And lastly, when we just look at all causes of cancer deaths in women, again, this ranks third, below lung and breast, and same with men. And when we combine this, it's the second leading cause of cancer deaths in America. So again, I harp on all these statistics because 90% of colon cancers can be prevented with timely screening and early intervention. And so, we really should be able to drop those curves down quickly. And why is colon cancer preventable? Well, there's a precursor lesion called a polyp. So that's when you hear when people get their colonoscopies and they have a polyp removed. Well, a polyp is a growth of abnormal cells that are growing rapidly, and it forms kind of like a little mound on the colon wall. And they don't arise overnight, so it takes 5 to 10 years for that polyp to develop and turn into a cancer. So we have a long lead time. It's not like this cancer popped up in a year in most patients. And they don't spread quickly. They're really slow-growing things, and so we have plenty of time to get them. They're not going to give you a red light. Nothing's going to go off in your brain, oh, you've got a cancer developing, get in. You have to take the early steps in getting there. We also know a lot of risk factors and genetic causes, so we know a lot about this cancer. So again, we can use those tools to our benefit. So again, here's some pictures. This is what a normal colon looks like whenever you get a colonoscopy. Nice smooth walls. This is a little polyp. This would be a really big polyp probably, and this is kind of what a cancer looks like. Now we only know after we do a biopsy, but if I saw this on a colonoscopy, I'd be really worried. And again, this whole sequence takes about 10 years, so about 5 years to develop into this polyp and about another 5 years. So what we want to do is we want to intervene here or here, and this is a snare where you can see we've cut the polyp off, and it's a nice smooth wall again. And so we can intervene before it turns into this cancer. And there's been lots of studies out there showing that detecting and removing polyps early on will reduce the incidence of colon cancer. So again, the natural history, we have a polyp, and in about 10 years' time, it'll develop into a cancer. And over several more years, it'll start to spread into the lymphatics and grows into the lymph nodes and also go into the blood vessels, and then it can spread to our liver and lungs. So whenever we talk about a colon cancer, if you've had any friends or family members that get it, we always want to know what the stage is. The stage really tells us how we're going to treat it and what the outcome is. And the stage, when we talk about this, it's made up of 3 characters: tumor, lymph nodes, and metastasis. So when we look at the tumor stage, we want to look how deep it's gone into the colon wall. There's multiple layers in the wall, and so we're looking how deep it's invaded. Then when we look at the lymph node involvement, we only know this after we've removed the colon and the specimen, but we want to see as cancer spread into the lymph nodes. That's kind of the cat's out of the bag, okay? It's spread outside the colon wall, and cancer cells could be elsewhere, and so that's when we institute other therapies like chemo. And metastasis is a fancy word for spread to other organs. So that's when it's got here into the bloodstream, and it's circulated up, and the most common place it lands is in the liver. It loves to grow there, and it can also bypass the liver and go to the lungs. So, whenever we'll look at the tumor depth, and we'll make sure we've got a pathologic diagnosis of cancer, but then the lymph node involvement we can only tell by taking the cancer out and looking at the lymph nodes under a microscope. And metastasis, that's usually when we do x-rays, CT scans, chest x-rays to look for spread. Then we take a combination, and I don't want to harp too much on this, but we can stage them as 1, 2, 3, or 4, and it's a combination of these letters. So an early stage cancer is invaded superficially into the colon wall. A stage 3 cancer spread to lymph nodes, and stage 4 cancer spread to other organs. And then again, our survival depends on the stage. So that's why it's a good prognostic factor, is why we do this. So stage 1 cancer, so these early cancers have a great cure rate. 5% survivability is 92%. The stage 2, it drops, and you can see after it's spread to other organs, our 5-year survivability has really fallen off. So ideally, we want to find polyps before they turn into cancers, but worst case scenario, if we are going to diagnose a cancer, I want to be diagnosing them up here where I can still cure them with surgery, and not on these stage 4 where they've spread to other organs and there's not as much we can do. Now you're going to ask, are there any signs or symptoms for colon cancer? And really there aren't great signs and symptoms for polyps, okay? There are rare polyps that can give you diarrhea and things, but for the most part those are asymptomatic. Most early colon cancers are asymptomatic, but if you or anyone you know develops these types of symptoms, which include blood in the stool, anemia, which would be found obviously whenever you're just doing blood work at your doctor, a change in bowel habits where the caliber of your stool gets pencil thin, or you get a lot of diarrhea, a bowel obstruction where you're vomiting and things aren't passing through, if you have unexplained weight loss, abdominal mass that you can actually feel sometimes, or just overall pain, something's not right. These you definitely want to get in and see your doctor, and we want to screen you right away. But again, you don't want to rely on these symptoms because they're not present in a lot of cases, and honestly, once you have symptoms, you usually have a more advanced cancer. So who's at risk? We have the average and the high-risk patient. So an average risk patient is over 50 years of age, has no family history of colon cancer, and I think this is a big education thing, polyps too. Okay, so if dad had polyps at age 50, I would actually put you in a higher risk category and start screening you earlier. And you're asymptomatic. The high-risk patients have all those risk factors we just talked about, blood and stool, change in bowel habits, etc., or have a family or personal history of polyps or colon cancer. Now again, 75% of patients are asymptomatic or have no family history. So this can be a silent killer, and that's why it's important really to adhere to screening. As you brought up earlier, there's lots of causes of colon cancer. It's not just one thing goes wrong. There's environmental factors that we can modify. There's age and time. We know as we all get older, people develop more cancers. And that's because our body's got a surveillance system, and it just tends to fail with age, or there's a higher likelihood of missing a cell gone bad. And there's also genetic susceptibility. So there are some inherited traits that make you a higher risk for developing colon cancers and other cancers. That's why we see these kind of run in families sometimes. So again, the risk factors for colon cancer are age, over 50, a personal history of polyps or colorectal cancer, genetic, so you can have familial causes, and they can be linked to other cancers. There's some syndromes out there linked to stomach and ovarian and uterine cancer that are associated with colon cancer. Diet, geography, physical activity all play a role. And inflammatory bowel disease, and if you've ever heard of ulcerative colitis or Crohn's disease, but those put patients at increased risk. So again, there are some family causes of colon cancer, and these can be some syndromes called FAP, HNPCC, and sometimes just a positive family history of having cancer. But for the most part, you can see 75% of this pie sporadic, just pops up. So just because mom didn't have it doesn't mean you don't have to get a colonoscopy. And some dietary risk factors that we can all work on. The increased risk of colorectal cancer, it has been associated with diets high in red and processed meats, high in saturated fats, so that's why the South does so poorly. We have a lot of fried food, and high in alcohol consumption. Things that are protective against the formation of colorectal cancer include diets high in fruits, vegetables, and fibers, milk and calcium, and folate. Other risk factors include obesity, physical inactivity, diabetes, and smoking. So all these things are just healthy lifestyle factors, but they really can help decrease your risk of colon cancer. So I'm going to talk a little bit about screening, and luckily we've moved beyond this. When we talk about screening the colon, we're usually going from the bottom end up. So we'll look through the anus, the rectum, the whole colon, and when we get down here, we know we've made it to the end of the colon because we see the appendix and we see the entrance to the small intestines. Okay, so it looks kind of like an upside down question mark. What's the benefit of screening? Again, we like to do screening early so we can remove polyps before they turn into cancers. And it also allows us to find cancers earlier when they're more curable. And we know that we can reduce the cancer-related death rate if we intervene early than late. So when to screen, and sorry this slide looks a little busy, but I just want to make sure everyone heard all these points. For the average risk patient, okay, so that again is no personal history of polyps or cancer ever in your life, no personal history of inflammatory bowel disease, and that's ulcerative colitis or Crohn's disease, and no family history of colorectal cancer or polyps, again, in a first-degree family member under 60 or a second-degree relatives of any age. So again, that's if mom, dad, brother, or sister had polyps at age 55, you would not fall in this average risk because you have a first-degree family member under 60 that has one of these lesions. So if you fall in this category, no one you know has it, and you don't have any personal risk factors, then you want to begin screening at age 50 for the general population. And this is something that's not really widely publicized yet, but a couple years ago, many of the societies came out with guidelines that for African Americans or American Indians, we want to begin screening at age 45, and that's because we know that African Americans and American Indians develop more advanced cancers earlier. So we want to start screening them at an earlier age. For the high-risk patients, this is really where you want to talk to your doctor, but again, if you have a family history of colon cancer or polyps and a first-degree relative under 60 or two first-degree relatives of any age, we want to start screening at age 40 or 10 years before that person developed a polyp or cancer. If you had polyps or cancers, we're going to screen you at different intervals. And if you've had some of these inflammatory bowel disease, we'll just put you on a different screening regimen, which we don't need to get into here. So what are our screening options? We've got a number of things publicized out there. We can do stool testing every year to look for blood in your stool. We can do a flexible sigmoidoscopy every 5 years with the stool testing every year. We can do a CT scan every 5 years, or we can do a colonoscopy every 10 years. And that colonoscopy is really the gold standard. I'm going to briefly touch on each of these. So fecal blood testing. You give a stool sample, and not quite like he's indicating here. But a stool study can be done different. There's a guaiac stool study and an immunohistochemical study. The guaiac study is looking for blood in the stool, but there can be a lot of things. If you eat a lot of red meat or beets or other foods, it can give you a positive result, and it's just from something you ate. The FIT test, which is the other one, is a little more sensitive, but still it's just looking for blood from the colon in your stool. Now, we know we just talked about we want to find polyps, right? Polyps rarely bleed unless they're just huge. Early cancers rarely bleed. It's not until you get that ulcerated cancer that it bleeds. And so it's not real sensitive in picking up, it's not a preventative tool to find those polyps, I should say. But it's, it's definitely going to help. So if it's the only screening tool out there, it's not a bad thing. And it can reduce our cancer deaths because hopefully we can find those earlier cancers. Again, it's not going to detect all cancers, and every test is a little different, and it depends on how it's performed. It has to be a fresh stool sample collected, and I actually know there's a lot of gynecologic offices here in the city even that collect it with a wooden stick. And if you stick a wooden stick in someone's bottom, you might hit their hemorrhoid, and then you're going to get a positive result. And so, it has to be done correctly too. But it's not really going to find those polyps necessarily. And then it also has a high false positive rate. So a lot of people do have hemorrhoids and other problems once they go to see their doctor. And so it can be anxiety provoking because you get this positive test, your doctor calls you, you have to wait to get an appointment to see me or a gastroenterologist, then wait to get an appointment to get a colonoscopy. So again, I think the pros are it's easy to perform and something we can offer to all the community. You can't show up in a van and get like you get a mammogram. You can't show up and get a colonoscopy. So we could, it's something we can promote, but the cons are it's not a preventative test, and if you have a positive study, you still have to go get that colonoscopy. A flexible sigmoidoscopy used to be done more. It's done less these days. But again, we talked about what the colon looks like. A flexible sigmoidoscopy just looks at this first 40 to 60 centimeters of colon. We call this our rectum, and then the first part of the colon here is the sigmoid, then the descending, transverse, and ascending colon. So it's just going to look at this first half, or first fourth of the colon. We know that a lot of cancers lie there. And that's the greatest population where we find cancers and polyps. So the benefit is if we see something here, we're going to tell you need the whole colonoscopy. The benefits of this are it's well tolerated. Usually you just have to do an enema. You don't have to do the big prep. And we can do it in the office with minimal discomfort. Doesn't require any sedation. And it can reduce cancer deaths by 60%. The cons are we're not looking at the whole colon. So I think if you're going to do it, let's try to look at the whole thing. And over half of cancers arise beyond the reach of the scope. So we know that if we see a polyp or we see something abnormal, we're going to recommend you go get that colonoscopy. But some people don't have polyps on the left side of their colon and they've got a big cancer on the right side. So we could still miss things. CT colonography I want to talk about because we all know President Obama got this. And I'm actually disappointed that he got this because I don't know that he really had an indication. And it's really not the gold standard out there. For patients. It's very expensive. It's a high radiation dose. And it depends which radiologist is reading it. Because this is a newer technology, the sensitivity ranges depending on whose hands it's in. There's only one center here in town that does these. Not all the places do. So luckily we do have one, so if someone needs it. But you've got to think about it. It still requires a full bowel prep. You still have to blow the colon up with air to see for polyps. And if we see anything, if you've got polyps or a big cancer, then you still need a colonoscopy. And it's not going to be done that same day. Because you're going to go home and eat. It's going to take 5 hours for the radiologist to read this, and you're going to get a call the next day. So you have to redo that prep. So I really find it's good for people who have an incomplete colonoscopy. Some people have real twisty, turning colons, and we can't get through them. And it doesn't mean you're blocked up. It just means we couldn't get through it that day. Or some people have a medical condition that inhibits getting a colonoscopy. They can't get sedation, they have a bad airway, or something like that. So this is a good test. I just still don't think it's really the best one out there yet. And colonoscopy, again, is what we would call the gold standard. And that's where we put a scope in through the bottom. We go the whole way up through the colon. And again, when we reach the end, we see the appendix, or where you used to have an appendix, there'll be a little stump, and we see the small intestine. So we've made it the whole way around. In doing this, if we see any polyps, we can remove them at the same time, or if we see any other large lesions, we can take a biopsy of them and send that for pathology. Okay. So the sensitivity is very high, 97% when it's done by a good endoscopist and you have a good bowel prep. It's both diagnostic and therapeutic, meaning we can see a polyp and we can remove a polyp at the same time. So it's one-stop shopping. If the test is normal, you're good for 7 to 10 years. So that's the good news. If we find a lot of polyps, we might ask you to come back in 3 years or 5 years. It depends what we find. And the National Polyp Study showed a 76 to 90% reduction in colon cancer in those who underwent colonoscopy and polypectomy. So you should feel good if you've had your colonoscopy. There are some risks involved. Small risk of bleeding, and we would take anyone off blood thinners like aspirin or Plavix. And ask you to stay off them for a week if we remove the polyp. There's also a small risk of perforation or putting a hole in the colon, which can require surgery at times. So that's scary, but luckily these are less than 1% of the time. There's a slightly higher risk of actually missing a lesion. So if your bowel prep's bad, we might ask you to come back earlier because we were afraid maybe we missed a real small polyp. So the quality of the exam is related to the quality of the prep. If the colon's still covered in stool, we're not going to see things. If you're clean, it's great. And to dispel a few myths, the bowel preps aren't awful, and I will tell you repeatedly, I have patients who come in after 5 to 6 years when they should have had it done, and they say, well, it wasn't that bad. And even if it's not the greatest experience in an afternoon, you're going to feel good, and you're good for 10 years. We do have some newer bowel preps out. I have one now that I'm using pretty exclusively that you do 1 glass of the prep stuff, which tastes like salty cherry water. I won't say it's great, but it's palatable. And then you drink a couple glasses of water. You get up the next morning and do the same thing. So it's 2 glasses of the prep. There's some pill preps out there and some other things. You can put flavoring in them. You're going to expect to go to the bathroom for 3 to 4 hours, but you want to be clean. It's not really worth doing if you can't do this. Yes? Say, I never even use a Go Lightly. So the Go Lightly is a gallon of kind of yucky stuff. So I actually started using Half Lightly, and as it would tell you, it's half the volume. And it came with 4 different flavors and stuff. And I still think that's a good one. The new one's called Soup Prep that I've been using pretty exclusively. And I have to tell you, people are whistle clean. I love it. And it's the 2 glasses. It's, I think, a 12-ounce glass of this. I tasted it because I wanted to know what my patients were having to taste. I made them mix me up one. And it kind of tasted like salty cherry water. So I was like, you can't tell me this tastes good. But I wasn't gagging on it. But you drink that, and then you drink 2 glasses of water. And what I really like about it for professional people who have working jobs, you don't have to start till 5 or 6 p.m. the night before. So you don't have to take a whole day off work to get a bowel prep. S-U-P-R-E-P. Soup Prep. Yes. Yeah. So that's called the Fleet Prep, and they actually took that off the market because that did cause renal failure in patients, and so you can't actually do that prep anymore. I used to do that a lot, and it would be in select patients, but the thing is sometimes we don't have a full set of labs when we're prescribing someone a bowel prep, and so, yeah, that one came off the market. So you actually can't do that one. There is a pill prep out there as well. Now, to me, that sounds awful. It's 32 pills. You have to take 4 pills every 15 minutes, but for some people who really can't drink much volume, but you're going to have to drink it. You're going to have to do it. But there are alternatives out there. Now, if you're a really constipated person and, that's the reason you're coming in to see me, we need to rule out a bowel obstruction, I might make you do a 2-day bowel prep. So, there's going to be some circumstances where your doctor says, no, you need something bigger. But again, I've had patients sit there and say, doctor, I've been worried that maybe I had colon cancer for 5-7 years. It's a bad couple of hours. But, again, then you can sit peacefully for 10 years if your colon's clean. And if not, hopefully we can find something. What I always tell patients is what's worse, a bowel prep and removing a polyp, or you coming to me and having a cancer that's spread throughout your body? And, we can maybe do surgery or something. This is a much kinder way of going. You want to catch it and prevent it and not have to undergo that big surgery. You're not really saving yourself if you're the one to develop cancer by skipping your screening. Now this is going to talk a little bit just about screening trends in the United States. So you can see we have done better over the past 10 years. We've gone from 40 to 55% of people in America being screened. But that's pretty poor statistics because 70 to 80% of people do their breast screens or cervical screens or prostate screens. So colon cancer, we really want to be up there 80, 90% of people getting screened, not down here at this 50%. But you can see, as I've talked about, the trend is for colonoscopies to be done more. Medicare will always cover these now. I think that had been an issue in the past. There's a law in the state of Louisiana that all private insurance companies pay for screening colonoscopies. So if you have insurance, there shouldn't be any trouble with that. And if you don't have insurance, there's programs out there. But you can see some of these other tests have kind of fallen off to the wayside. As we've said, colonoscopy can be both diagnostic and therapeutic. But the sad truth, again, is I keep harping on this, but 80 to 90% of colon cancer is preventable, but most Americans are not getting screened. We know the survival can be really high when we find an early colon cancer, greater than 90%, but still we're only finding those early colon cancers less than 40% of the time. And so that's why our death rates from colon cancer really haven't improved, because we're not finding them early. We're still finding them advanced, and people have bowel obstructions and bleeding and come into the hospital with problems. So in 2008, you saw only about 55% Americans 50 years or older had been screened. And that's not necessarily even a colonoscopy. That could be the stool study. But they had done something to try to prevent. So again, I hope the biggest takeaway point here is to remind your primary care physician, remind your family, remind your friends, get your screening exam. Don't be one of these statistics. I want to just touch on Louisiana because we do awful in our health here. We're kind of ranked, I think, the second most unhealthy state in the country behind Mississippi. But when we look at colon cancer, we're ranked 43rd in the country for screening compliance. And so, we're way down here. We want to be one of these dark blue states like Connecticut. And when we look at colon cancer statistics, we're number 5 in the number of colon cancers reported each year, and we're number 3 in the number of deaths from colon cancer each year. So we have huge strides we can make to improve those, and we just have to start from the ground up. So, make sure you get screened and make sure everyone you know gets screened and teach them these facts, because I think some of it's just education in the community. I don't think we've done as good. Colon cancer is not something people want to sit around at dinner parties necessarily and talk about. But I will tell you, being a colorectal surgeon, that once people know that you're willing to talk about it, they love to. So don't be fearful of bringing it up. I mean, I sit down to get my hair cut, and they're like, oh, I have hemorrhoids. No, or, oh, my brother had colon cancer. People will talk about it. We have to get it out there. So once a cancer develops, surgery can be the best chance for cure. And so that's, kind of why I chose to be a colon cancer surgeon here. Once we diagnose it, we kind of talked about this, but briefly we're going to stage you. So I'm going to want to make sure that we've got a diagnosis from a biopsy that's been looked at under a microscope. We're going to do some CT scans and blood work to try to see if it's spread. But those early cancers can be often cured by surgery. So if the cancer is not spread to other organs or the lymph nodes, all you need is surgery, okay? If it's spread to other organs, then we're going to add chemotherapy after your surgery. And for rectal cancers, we add some radiation often. Again, most tumors can be removed and the bowel put back together. So I know some patients come in and they say, I knew I had cancer. I've had symptoms for a year or two, but I was so fearful I didn't want a bag. I don't want a bag, doctor, so I wasn't going to come in. Well, most people don't have to have a bag, and if they do, sometimes it's just temporary while we let things heal. Rarely do we have to give someone a permanent bag. The surgical resection depends on where it is. So, if you've got a cancer over here, we want to remove the blood flow and all the lymph nodes that would drain that. So we would remove this whole right colon. If you had a cancer over here, we're going to take the blood vessel high, and the little lymph nodes line these blood vessels. And so we take the blood vessel high, and we take that segment of colon and then put you back together. And again, the goal is to remove the affected portion of the colon plus 5 centimeters on each side to make sure that's how we know it doesn't really spread along the wall more than 5 centimeters, and that we get all the draining basins that could have cancer cells in them. Some of the new things out there, I'm sure everyone's heard of minimally invasive laparoscopic surgery. But that's where we put small poke holes in your abdomen, and we can put long instruments and a camera, and we can mobilize that colon because, this colon goes the whole length of the body. So if I've got to remove this whole portion of your colon, I actually have to mobilize all this up off your kidneys, your spleen, your stomach, your small intestines so that it'll reach down here without tension. So I can do a lot of work through these little poke holes. You still have to have a little incision to get that colon out because we've got to get it out in one piece. But, I would say 6 centimeters would be my standard incision to get a piece of colon out. And sometimes we can even do it through a little, kind of C-section scar, the little, Finan steel or something low down here. So it doesn't have to be morbid. And actually the benefit isn't necessarily cosmetic, although for some people that's a big thing. But there are a lot of other benefits. We know with making these small incisions, we have a reduction in the postoperative ileus, or that sleepy bowels, so the bowels wake up faster. And then that means you actually get out of the hospital at least a day faster. People have less pain, so they have to use less pain medicine, which makes you feel kind of crappy. We know that people get back to their activities faster, they're eating faster. And we also, we like to tout the improved cosmetic results. We also feel that you form less scar tissue inside your body, which can lead to problems in the future with bowel obstructions or things like that. So there's a lot of benefits of laparoscopic surgery. So if you're a candidate, this is the way I'd want to go. For rectal cancers and big rectal polyps, there's also a new technique that I'm offering at Our Lady of the Lake, and it's called transanal endoscopic microsurgery. And what that is we put this, while you're asleep, we put this big scope in your bottom. But for the first 20 centimeters of your rectum, if there's a big polyp that we can't remove with a colonoscopy, I can remove that, and I can remove it in one big piece. So we know if there is a little cancer in there, did we get it all out? Do you require more surgery or things like that? Yes? We usually don't. It's separate. It's separate. Because the way we do hemorrhoid surgery can be we either put a rubber band on them or if we have to cut them out. And honestly, most people's hemorrhoids get flared up whenever they get a bowel prep, okay? So everyone has hemorrhoids. That's some vascular tissue around the anus. There's some blood vessels inside the rectum and outside. And so whenever you get diarrhea, I'm sure everyone's had some problems with childbirth. A lot of people get hemorrhoids flare from the straining, or when you get a bad, flu bug, your hemorrhoids are going to get flared up. And so I find people's hemorrhoids get flared up too from a colonoscopy prep sometimes because you just had diarrhea for 4 hours. So your hemorrhoids are going to be a little bit bigger. And so I don't think it's the right time to fix them, but it's also not the techniques we use to fix them. So, yes? Or most everyone, they're blood vessels that we have. We say we have hemorrhoids when they get enlarged and flared up or start bleeding or cause us pain. That's when you're going to show up to the doctor and say, I have hemorrhoids. But everyone's pretty much got this hemorrhoidal plexus. It's just, And so to treat that, we want to just have good bowel function, a lot of fiber and water in our diets, and have nice, easy bowel movements. And then they really stay relatively quiet. It's whenever we get into the straining or a lot of diarrhea or a lot of constipation or gaining a lot of weight where it puts a lot more pressure down there that they become big and cause us problems. So again, prevention is key. And so what can you do? And I hope you take this away. Be healthy. That's kind of the easy answer. You want to eat a diet high in fruits and vegetables and whole grains and fiber. Okay, so you do not come to my office pretty much without walking away with a cup of fiber. So it's like Consul, Metamucil, things like that. Americans really don't get enough fiber in our diets. You need 25 to 30 grams a day. And that's a lot. An apple's 3 grams, and you can look up all this. But most people need a supplement, okay? But that will keep your colon healthy and happy and actually prevent you from getting the hemorrhoids and the other things. You want to eat a diet low in red and processed meats, because we know those are carcinogens or precancerous causes. You want to drink alcohol in moderation, which for women is about a glass a day and for men 2 a day, or not at all. You want to stop smoking. And you want to exercise most days of the week. We know that people who exercise regularly actually have lower rates of colon cancer. And you want to maintain a healthy weight. So obesity can really increase your risk of colon cancer. And lastly, get a colonoscopy when it's recommended. Don't wait 5 to 10 years. And so get involved. Be an advocate in the community. Remind your friends and family. Remind your doctors that this is your time and you want to get this done. And again, if you want to help us support the cause, we're really excited. Marilyn in the back has been instrumental. She planned this wellness day, and she's really helping us get this race planned as well. But it's going to be a 5K run and walk held right here on the grounds. And all the money we raise, we're going to keep 75% of it locally. I should say not all, but 75% of it. And we're going to help to start doing more education and hopefully some treatment options with that money. So I think it's a great thing for the community, and I hope you all can get out there and help support us. We should have some information available soon, but if you go to active.com or just go to getyourrearandgear.com, you can find us. Here's several other resources. So if you have questions, you can find anything on the internet these days. So I just encourage you to go to reliable sources. So the American Cancer Society, I would trust, the National Cancer Institute. This is our national organization, the American Society of Colon and Rectal Surgeons. There's coloncancerprevention.com. And my office has a website called brcolonrectal.com, Baton Rouge colonrectal.com, if you remember that. And I have most of these websites linked on our webpage. But don't just read any website. We know we can find anything out there. But make sure you're reading a reliable source.
So what I thought you said was that general polyps do not age, and it takes more than 5 years to develop cancer. So if you have a colonoscopy every 5 years, is there really much value in yearly people?
No, you don't need to do any of that. So
My doctor has to do the fecal one every year, but I need to get a colonoscopy
you
every
really,
5 years, and it just seems like a waste.
yeah, you really don't need to do that. if you do the flex sig, and that's maybe where he's thinking, if you did the flex sig, then every year we want to do the stool studies. But no, you don't need to do that every year. There are some cancers, so if you had a family history, there are some cancers that can grow more quickly over a 3-year period of time. So, if you had a sister, say, that had colon cancer when she was 30, that's kind of a scary thing. I'm worried about having a hereditary syndrome called HNPCC, and I'd want to screen you every 3 years. So, there might be things like that where you need to go earlier. But if you're average risk, never had polyps or things like that, you can just do your colonoscopies. Then it's not really a risk. Some people get confused by that, but yeah, if Grandpa had it at 80 and no one else in the family had colon cancer, that's really a second-degree family member. You fall in that normal risk. Yeah. Again, and no other family members with polyps too? Okay. So that's a big question to ask too, polyps. And that's where I think a lot of, and I'm not criticizing anyone, but that's why I specialize in this. I don't think that's one thing we always look at, with all the doctors. I don't know if everyone's answering the question, did anyone have polyps too? Because that can bump you up. But no, that's one first-degree family member over the age of 60, so you would still fall in the average risk category. Now, that being said, if someone's really scared, mom just got diagnosed with colon cancer at 65, and I'm really worried, I really don't have a problem doing your colonoscopy a little early. I want people to have peace of mind, Again, this is preventable. So, there's going to be, we don't say it's 100% preventable because you're going to have those people who get it at a young age, or you're going to have some of those people that just develop it really quickly, or, something got missed on a colonoscopy. So we're not going to prevent them all, but we can sure do a lot better. Yeah. Well, it depends on your risk factors, okay? So if you have no risk factors, since you're African American, I'd recommend starting at age 45, okay? If you have any of those risk factors or some family history, then we want to start earlier. At 50, then you want to definitely start by age 40, okay? And if there's any other family members, we might even want to start earlier, okay? Yep. All right. Any other questions? Oh, yeah. Yeah, that will put you at a higher risk, so, yes. That's actually diverticular disease, which is a blister on the colon that most Americans get because we don't eat a high-fiber diet. So, 70% of people by the time they're 70, 80 are going to have diverticulosis, which is these little blisters. If they get impacted with a stool ball or something blocks them, they can get infected, and then you get what we call diverticulitis, which is an infection of the colon wall. I'll say you're going to read lots out there. They say don't eat, popcorn seeds and nuts and stuff because it can block them. I'm a colorectal surgeon. I really don't necessarily advocate that. How often do you see a popcorn seed come out in your stool solid or a nut come out solid? So I've never been doing a colonoscopy and seen a seed necessarily stuck in there. Every once in a while, like maybe a watermelon seed or things like that. But, if you're going to eat some almonds and chew them up well, I think you're okay, personally. Correct. It's not related to cancer. It's related to more constipation and high pressures. And so you actually get, the best way to describe it is you get little hernias through the muscle layers in the wall. A colon is a circular structure. So if this is your colon wall, you have 3 muscles bands that go like this around the colon. And when it gets down to your rectum, it forms 1. But whenever you get pressure that's really high in there, you have weak points between these muscles. So like right here, a blister would pop out, or here. It's not really a blister, but that's what it looks like. It's the easiest thing. It's really a hernia of the layers of the wall between the muscles. It can get stuck. It's more usually hard stool. So again, I would say more than really having to focus on like never eating a peanut again, make sure you really, really focus on getting all that fiber and not getting constipated, okay? Your fiber will give you really big, bulky stools, but they come out in one piece, and you don't get these little hard stools that can get stuck in there, and you're not straining, which increases the pressure and will make you get more diverticulosis. Okay? Yeah. Yes, and it's not the most palatable, I'll tell you. Most people don't love me for saying it, but once you get in the habit, it's fine. Fiber is a psyllium product, so it's a non-absorbable plant product that adds bulk to your stools, okay? You can get it in things like oatmeal, fruits and vegetables and things like that, beans. But again, most Americans just don't eat enough. So that's what I say. If you're not, and you're not necessarily going to eat the same diet every day. So people come in to me and they've had hemorrhoids, and I tell them they have to go on this high fiber diet, and they're real good for 2 months. Their hemorrhoids go away. They're not in pain, and they go back to their old eating habits, chicken and Coke and whatever every day. So that's where I say, if you're not going to eat a good diet every day, just add the fiber. And so good products out there. I recommend Consul, and that's what I would take every day. But it is a thicker agent. But you have to look at how much you're getting. You put a teaspoon in your orange juice, or I recommend putting it in a juice or a flavored water or something like this. But you mix it up, and it comes with little cups, so you can shake it up good and drink it. Consul gives you 6 grams per teaspoon. Metamucil is about 3 grams. Benefiber, I think, is about 3 grams as well. There are fiber tablets out there, which I really think are a waste of money, because most fiber tablets only have 1 or 2 grams of fiber in them, so you're better off just eating an apple that has 3 grams. So it's counting calories, kind of like you would count anything in your day. You can buy flaxseed at Whole Foods and sprinkle it over your cereal, and that's an easier way. My husband and I make smoothies every morning, and so he puts that in along with strawberries and blueberries that have a lot of fiber, and we get a big fiber bolus that way. You don't really taste it when you hide it in other things. So you can either eat it or take it as a supplement, but it's really important to get that fiber in your diet. I think it comes in more of a powder form, and I've actually learned this because I send a lot of people to physical therapy because they get pelvic floor problems. And one of the therapists over at Brown Rogers taught me that. She sends a lot of her patients over to Whole Foods, and I guess you can buy it in that where they've got all those grains and stuff, and you can just sprinkle it over your food. Oh, really? Yeah, and I've bought that before, and those bottles, unfortunately, don't always tell you how much fiber you're getting. So I never know how to recommend that to people, because I've gone into Whole Foods to look at that, because I always... How much fiber is in flaxseed oil? Yeah, but I don't know. You're probably getting a couple grams of fiber, but none of the labels on those things really tell you. So I'm sure it's good for you, but as a matter of trying to count and see how much fiber you're getting, I don't know how to tell you. 25 to 30. I don't really know the answer to that. I'll be honest. Yes. Oh, absolutely. I don't know if I have it on my website, but if not, I can try to add that on there. When people come to see me, I've just got a little handout that was passed along to me. But I think if you just go on the internet and pull up Google and ask for fiber content, you're going to find a lot of those things. And you'd be surprised. I mean, that's why a lot of people come in and they say, oh, but doctor, I eat a salad every night. Well, they eat an iceberg lettuce salad with some cucumbers in it, and that really has no fiber. Iceberg lettuce has nothing in it. So you need to look at what has fiber, and, it's an eye-opener. All right. Well, good. Well, thank you all. These were great questions. I appreciate you coming, and I hope I've given you some good information.